Let's try that again.
Okay. So I think what we went through was really around, what is the changes since to 2019, and really celebrating, what are the improvements that we've had over that time, but definitely, where are the areas that we do need to look at. So I'm just going to go through to the end of my slides and really around, what are the major changes and major issues. So in terms of elimination of vertical transmission, what we do need to look at is really around, closing that gap in terms of the new vertical HIV transmissions, preventing incident infections in women living with HIV and their partners, really emphasizing this U equals U principle within this this group, expanding the use of PrEP in this at-risk population, and the regular testing of pregnant and breastfeeding women with early ART initiation. The other thing is, and we've seen this in our clinics and in our wards, is really around people living with HIV who have become disengaged from care and who are not biologically suppressed. And we do need simpler regimens, better delivery systems that don't interrupt their daily lives in order for them to remain in care. And really looking at interventions to keep them in care, example, peer support and other interventions. In terms of closing the gap in terms of diagnosis, we find a lot of failures in terms of early infant diagnosis. We're doing extremely well with birth testing, but from 10 weeks onwards, the 10-week, 6-month, and 18-month testing prior times, it decreases thereafter. And we really need to increase that, encourage mothers to come in for their testing, and that we don't miss these opportunities. And we often see children where they have been for care and they've been for immunization and they haven't had their test done. We need active tracing of these children, identification of incident infections in women living with HIV, and testing of those infants. Point of care early infant diagnosis does allow same-day resulting, and that's something that we need to discuss as a country in terms of where we place these interventions to make it easier for diagnosis to happen. And we have to ask, is early infant diagnosis sufficient? Do we need to be doing something different, really around community testing and offering testing at every health interaction, which is there in the guideline, but often doesn't happen. And as I showed in my talk, early adolescence is another major area where they're at risk, and really offering tailored interventions to them, which include self-testing, peer support, and engagement outside of the healthcare system, where they often feel victimized and not engaged in care as part of the health system. And then lastly, I think in terms of linkage to care, I think certainly we found that same-day ART start, especially in stable patients in an outpatient setting, allows us to get better initiation of treatment and starting of treatment in these in children and in adults. And then maintaining biological suppression, and that's keeping children and adolescents living with HIV engaged in care, biologically suppressed with better regimens, better delivery systems, and support structures to ensure that they remain in care. So I think I just want to end off with this really statement at the end was really around guidelines, and we've got one of the most progressive guidelines in the world. Certainly, we often ahead of WHO changes, and again with this guideline that will be the case. And having just guidelines is not enough, and we do need to convert guidelines into practice. And part of that is to ensure that we have an accountable healthcare system that makes sure that where things go wrong, that we accept that and we correct it, but also where there's a positive outcome and there's adequate amount of work done, that we acknowledge that from happening. So I'll just quickly summarize, and hopefully I do justice to it. So Helena went through, really the question around, this framing of the, mother-to-child transmission. And that's been a topic of hot debate, and Helena went through, some of the patient-centered approaches in terms of not having victimizing language in our medical terminology. And certainly when we speak about mother-to-child transmission, we're often putting an over amount of blame on the mother. And we're not seeing it in the context of, the community and the family in which this mother lives in. And the other aspect around it is this over emphasis on the one aspect of just infant transmission, and the importance of the mother-infant dyad as a health system. And we do need to see that in order for a child to do well, that mother-infant dyad needs to be a intact, healthy, successful partnership. And the idea is to change that framework to be more family-centered, and looking at family-centered vertical HIV transmission is probably the terminology that we'll be using going forward, that emphasizes both that the intervention needs to be at a family level, supporting mothers and their partners and their families through the process of not only preventing HIV infection if they are HIV negative, but also supporting them in maintaining engagement in care, biological suppression, and maintaining their own health in order to effect changes in terms of the infant health. Some of the changes that are related to the vertical transmission guidelines are around that level of viral load, and our current viral load at which we identify as being high risk or higher risk was for many years stuck at 1,000 copies per mole. In the new guideline, that level will go down to 50 copies per mole. So that means we are more strict in terms of where we classify an infant as being high risk. The regimens in terms of infant prophylaxis remains the same, with high-risk infants getting AZT and nevirapine, and low-risk infants getting nevirapine only for 6 weeks. In addition to that, there's an emphasis on the, or re-emphasis on the viral load done at delivery as a final arbitrator of this determination of HIV risk. So if that viral load at delivery is not available, the default position is that you will treat that infant as high risk. So what that means on a practical basis is that majority of infants will be considered to be high risk at the time of delivery and on discharge from hospital, and that decision in terms of continuing of high-risk prophylaxis will be reviewed at either the 3-day or the 5-day well baby check, where the mother's viral load will be checked, and to ensure that there's a linkage between infant care and maternal care, and ensuring that the mother gets additional support to reduce her viral load. So those are the kind of the headline changes to the vertical HIV transmission guidelines. In terms of the pediatric guidelines, I think the huge change is what we've been waiting for many years, is really around a alternative to lopinavir ritonavir syrup. As many of you treating young children know, it's extremely difficult to maintain high levels of adherence to lopinavir ritonavir syrup because of its palatability issue, and we really need to be moving to a easier to use formulation, which is a dispersible dolutegravir formulation, in combination with the current abacavir 3DC dispersible formulation, which is available, but there's still teething issues in terms of availability at a local level. What this allows for in especially young children is that it allows for a once daily acceptable, palatable regimen for children from 1 month of age and 3 kilograms, which is a huge game changer from multiple syrup formulations twice a day. So that will impact going forward, and we're hoping that these guidelines will be implemented from the 1st of April, but certainly I think there'll be a lag period as this transition happens and availability of these optimized formulations become available. So we envisage that we will now have all individuals starting on antiretroviral treatment on a dolutegravir-based regimen, whether it's an infant, child, adolescent, or an adult, which is more durable and once a day and easier to use. And that transition will happen over the course of the next year or two. Yeah, so I think that I'll stop there, and maybe I'll invite either Helena or James, maybe if I've left something out from my summary.
Helena or James, go for it, Helena.
No, thank you, Mo. I think that was a wonderful summary of the discussion we had this morning.
James, anything to add from your side?
Thanks, Mo. I think that pretty much covered it. The one thing that comes to mind is in the new FC-VTP guideline, what was previously PMT-CT guideline, the wording, again, a wording issue around rather than high transmission risk. I think what was put in was universal dual antiretroviral prophylaxis. So this kind of idea that becomes the norm and the standard, that, as you said, the vast majority of newborns who HIV exposed will go on to dual ARV prophylaxis. So it's not necessarily as it were, stigmatized as high risk, but that standard intervention with the possibility that when you know the mother's viral load result, that may be reconsidered and refactored and may revert to one drug prophylaxis. So again, it's how it's put across to people, mothers and families of newborn babies. I think the wording's important. Thanks.
Brilliant. Mati, I'm not seeing any new questions in the chat group yet. I'm going to suggest that we start with Helena's case study and see how we go. Helena, do you want to share slides? How do you want to do it? Or do you just want to...
yeah, I'll see if I can share.
Perfect. That looks great.
Okay, yeah. Awesome. When Mo said what transpired this morning, he forgot to inform people that I forgot how Zoom worked. But in any case, let's start with this. And I mean, if anybody wants to comment, please feel free. I can't see the chat, but put up your hand and Mignon or Marty will interrupt. But basically, a very common scenario that we're seeing, a 33-year-old lady who was living with HIV and initiated on a standard first-line regimen. And I want to highlight here that she was initiated on dolutegravir 1 month before she fell pregnant. And her viral load at week 32 was 900 copies per milliliter. She had a good CD4 count and a negative rapid test for syphilis at 32 weeks. So her infant was born at 36 weeks gestation with a good weight. The baby's looking well, breastfeeding well. And the question comes to mind, what bloods would we think of doing on the mum and the baby? And I'm going to basically just take one step back and remind people that we are not now, we are not concerned now anymore about women taking dolutegravir in the first trimester. So in the past, where there would have been some concern with the signal for neural tube defects, we are not considering any changes. But let's think, what must we do now? Basically, I'll ask Mo. Do you want to test the HIV in the baby? Do you want to do viral load on the mom? Resistance test because a viral load is 900, some syphilis serology, all of that, and a full blood count clotting profile and a COVID test. What would you like to do for mom and a baby like this? And I'll just remind the audience, the mom's viral load at 32 weeks gestation was 900 copies. She's got an okay CD4 count, a negative rapid test for syphilis at 32 weeks. Emma, what would you do?
So I think the one thing is really around, again, I think if we're looking in the context of the new guideline, is around over-reliance. You know, we previously, I think we maybe had a over-reliance in terms of looking at the testing early on or mid-pregnancy. So certainly, I think, you know, a repeat viral load in that mother at delivery is extremely important. The other thing is, again, as many of us are seeing in our clinics, is we having this resurgence of syphilis in the mother, and in pregnant women, and certainly there should be repeat testing late in pregnancy, and we know that our HIV testing has to be done at delivery. So if you're a student and you just knew that you had to do an HIV test on the baby and you had to do a viral load on the mother as part of standard of care, you'd choose all of the above.
Yes, I think I would agree. We'll basically do all of that, and then obviously the kitchen sink that I added, mostly unnecessary. And I just want to remind people, part of our discussion this morning was that we often see the low level of viremia at delivery. It's in about 25 to 30% of deliveries, and 91% of the transmissions are happening to those infants. So that's why we are really trying to see how we can address some of those issues with tweaking the guidance that we're giving.
Guys,
so
I've got a
James,
question from Nompumelelo.
Okay.
I don't know if that's relevant to that slide, Nompumelelo. Can you unmute?
I don't know if her hand is accidentally on.
Okay.
Okay.
Maybe she can
All
just
right.
post.
But carry on then.
If you have a question, please put it in the Q&A and we'll definitely get to it.
Yeah.
So we're going to ask James. James, we know that in the past we said viral load of 1,000 was our cutoff for making some decisions, and what do we do with this infant? So it's 900, and now there's this story of 50. What kind of preventative antiretrovirals would you provide for this baby, or is it okay because the mom's on ART in any case?
Have you got the delivery viral load result back, Helena? I didn't get that. Is it 50 at delivery?
No. We just took blood. We just took blood, and this baby's got to go home.
Yeah. Okay. So, I think as Mo's outlined, and what we've been doing in the Western Cape province for the last 2 or 3 years has been, this approach of saying, well, we want to know what the viral load was in the blood at the time of delivery, given that the actual delivery viral load during labor and delivery is the key arbiter of transmission at that time. And even though 900 a month before delivery is not a bad viral load, and we know that dolutegravir does drop viral load quickly, this pregnant woman, or this woman, started TLD before she became pregnant. So there is a bit of a concern here that why was her viral load still not fully suppressed at 32 weeks, and is there perhaps an adherence difficulty going on? So essentially, I would say she gets AZT twice a day and nevirapine daily now, the baby, at the time of delivery, until such time as we get the delivery viral load result back. And then we can review that and recategorize her as, yes, indeed, the viral load is not less than 50 at delivery, and therefore she continues on the dual ARV prophylaxis, or it's less than 50 and we can step down to nevirapine alone for 6 weeks.
So how much should we dispense? How much AZT should we dispense for this baby? Full 6 weeks, or 5 days, or 10 days?
Yeah, so this was interestingly and was debated, because clearly in those patients where if it's going to stop on day 3 to 6 when the mother returns, hopefully, and that's a hopefully to come back for a postnatal check, but also to get the baby's PCR result and her viral load result, is that there'll be some AZT wastage. But the recommendation is really to dispense for 6 weeks, which is covered by 1 bottle anyway, if you look at the volumes and the dosing. And we would ask the mother to bring back her medicines with her, not that we would take it back and give it to somebody else, but so we could explain carefully what would be going on. But I don't think the recommendation would be to give for 3 days or 6 days in case this mother doesn't or can't return then for a result. And hopefully she would then continue on the 2 drugs, even if she didn't come back.
Yeah, and I think that's really from a pragmatic approach, what the guidance will suggest is that you dispense for 6 weeks, and then if mom doesn't come back, then she will have appropriate prevention. And if she does come back, you can have an intervention. And I think this needs to be quite clear in the facilities that we're working, that this wastage, in inverted commas, is actually factored into the new guideline that we are planning to disseminate hopefully very soon. So on day 3, the baby came back, and now the mom's viral load is 400 copies. So it's down. She shows you that syphilis serology was negative at delivery. The PCR of the baby is lost in the lab, too little blood, something happened. Now, what would you do, Mo? What would we recommend in this situation?
So again, I think in terms of this, the current, the new guidance is, that we're dropping that viral load, down to 50 copies per ml. So again, the infant prophylaxis will remain at this higher risk prophylaxis and will continue on AZT nevirapine. I think together with that is an engagement with the mother and ensuring that there's ongoing support and trying to see what are the difficulties or issues that you can resolve to improve adherence if there is adherence issues. And certainly, I think in terms of the PCR, we're going to have to repeat that the HIV PCR on the baby, and make sure that you've done enough bloods.
And the mom's now been on treatment for close to a year, and we're still seeing 400 copies. Are you worried about antiretroviral resistance in this mom, or not so much?
Yes, I mean, so that's one of the ongoing issues is really around what is the long-term consequence of what was previously termed low-level viremia, and certainly from some of the studies is that prolonged low certainly I think you're allowed to have a blip and you come down, and it doesn't seem to be results in significant amount of issues and impact in terms of your long-term suppression. But if you remain in this phase of long-term low-level viremia between 50, and certainly I think there's some debate about whether it's 200 or 50. But I think if we just put into one bucket of low-level viremia, with a prolonged period of time, there's a an issue around increasing resistance. And so I think there's a comment in the chat around mutations that you can acquire with this low-level viremia. So I think it's still something that needs to be considered. I think one of the technical issues is really around, and it's something we're going to be dealing with, is the laboratory in terms of the ability to to do a resistance test and amplify that virus. A majority of our laboratories are only able to amplify at a viral load of 1,000. So unless we're doing deep sequencing and we can able to look at these lower levels of viremia, we may not be able to do a resistance test. But I think the point about it is that you can't really sit still and do nothing. You really do need to engage and make sure that if there's any issues, you've addressed them as best as possible.
Yes, I think the point here that I think is very important is if we're sitting on the pediatric side of this, and from a selfish perspective and completely against the principles that I spoke about to mom, selfishly we are interested in the infant. So unselfishly we need to help mom and address issues that may be making it difficult for her to adhere to therapy, because we also know that she may be very vulnerable in this postpartum period. I'm going to just skip through and show you kind of a summary of the guidance that we also showed this morning. But as we've highlighted here, the birth viral load is really where we're going to decide, and we're going to give everybody 6 weeks of AZT, and when they return between day 3 and 6, we would actually make that final decision. And if they are having viral load more than 50 copies, we will continue for 6 weeks with the AZT, and we will continue with the nevirapine once a day until such a time as it is appropriate to stop. And remember that we will do the viral load. I think I made a mistake there, every 6 months in the moms who are suppressed and breastfeeding. If there is new increases in viral load during the breastfeeding period, again, we need to address the adherence, and again, we need to basically make sure that we are able to provide post-exposure preventative therapy, so you can actually reinitiate AZT and nevirapine. I think I'll stop there so that we have enough time for questions and also for James and Mo's cases.
So I'm just seeing quite a lot of, Mati, go for it. I'm seeing quite a lot of questions in the chat. Did you want to go for that?
Yes, I want to go for that breastfeeding, mixed feeding question. So Tiago has actually put a very good question out in the chat. Moms who are not virologically suppressed and are struggling to produce enough milk soon after giving birth. Is mixed feeding appropriate for those cohort of mothers while they are improving on their own milk production? And should they be exclusively formula fed until they have enough breast milk production in the absence of donor breast milk? And I think that's something that practically comes up every single day. Do you have some advice on those cases?
Yes, and the advice might depend quite a lot on who you are, but my advice is that whatever makes life hard for the mum is bad for the baby. And I think we do not want to make life harder for mothers. So my personal, possibly, and I'm sure James and Mo would disagree, and please don't hunt me down, but I would suggest that mom continues with breastfeeding as much as she can, because in the end, that's what we want. We want her to be able to breastfeed. We are giving infant preventative therapy. We are giving supportive care. And I think here you need help from people. Make sure that she's able to latch, that she's able that the baby is able to suck. And then we know that that can take a little while. So as long as the baby's well and you can support the mom, that's okay. But for me, and this is my personal point of view, if you see after a while that it's too much of a struggle, I tell moms to mix feed. But I'm sure somebody will now immediately send a child health expert to my door. But I think maybe
maintaining sanity in the mother and the child, Helena, isn't it?
Yeah, I think there's difference of opinion here. I mean, you will often hear people say that there is no mother that can't breastfeed. But we also see mothers who are really, really struggling, and we shouldn't make life hard for them or make them experience guilt because they are struggling. Sometimes baby friendly can be a bit mom unfriendly in my view, but maybe James and Mo will have a different view on this.
Happy to comment, James here. Yeah, look, my views are similar to yours, Helena, and I think, you know, a kind of move away from this very hard line, clear-cut sort of exclusive breastfeeding or exclusive formula feeding. The reality is that this happens a lot all the time of mixed feeding, and particularly early on when there is you know, taking a bit of time to establish breastfeeding. So I think the more recent paradigm is that any breast milk is better than no breast milk in the context of a mother who's on a suppressive ARV regimen and a baby who's on postnatal ARV prophylaxis. Obviously, the postnatal ARV prophylaxis doesn't continue, you know, throughout the period of breastfeeding, but hopefully breastfeeding, you know, is established during that first period of 6 weeks to 12 weeks when the child's on prophylaxis. Also, the risk of transmission through breastfeeding with a viral load in this mother that came back as 400 copies is very low. It's not less than 50, but less than 1,000 copies breastfeeding transmission is a lot less than once we're getting higher viral loads. Certainly, it's nowhere near the rate of transmission of intrapartum transmission during labor and delivery. And with improving adherence and counseling, this mother's, you know, moved her viral load. Well, her viral load's 400, and there's no reason why it can't and won't be less than 50 copies in the days and weeks to follow. So I think breast milk is so beneficial, and I think any breast milk is better than no breast milk, provided we're doing everything we can to suppress the mother and protect the baby on ARVs. You know, the challenges do arise when you get viral load elevations or new diagnoses later during breastfeeding, because sometimes you've missed the boat and it's too late, and the transmission has already happened by the time you try to intervene. But that would be my view on that. Yeah.
Okay, thank you so much. And the other side is then kind of true, but you've answered it mostly, James, is to say that if a mom is virologically suppressed, it's kind of safe that if she struggles, to say that it's actually really safe then to mix feed. Is that okay assumption to say that you can actually not encourage them, but I kind of reassure moms that is suppressed, to say that if you really struggle, don't make it harder for yourself. It's okay to mix feed.
Yeah, if that's directed at me, yeah. Look, the goal is always exclusive breastfeeding. There's no doubt about that, for various reasons, not just HIV transmission, and that should be the aim. But mixed feeding is a reality, and the issue is just to focus on the maternal viral suppression, and that's what TLD is so good at doing, provided you take it. And it's easier to take, and it rapidly suppresses viral load much better than our previous regimens. So I think there just shouldn't be a punitive approach to it. It's not like laissez-faire, it's great, it's fine, why don't you just mix feed? But in reality, breast milk benefits are there, and whatever we can get, we'll take, sort of thing. I think that's the way I would approach it.
Okay, great, thank you.
Really, so the other point I just wanted to make was really around, I mean, there is a element of a question mark here. Certainly, I think what we were saying, before was really around, in mothers who are failing a second-line treatment, especially, lopinavir ritonavir, which was our second-line option for adults. We were always concerned if they're failing that regimen, there's a potential for transmission. And we don't really know about dolutegravir. So I think it's something that, we're going to have to watch for, and really around, how quickly dolutegravir resistance emerges, and monitor as we roll out the dolutegravir program, specifically around its transmission risk to infants, around transmission of resistant virus. So there's a big question mark around this, and I think that will, in the coming years, we'll have more data and a more solid answer for that.
I mean, I would just add that, I just really, really hope that by moving from less than 1,000 copies to less than 50 copies, we don't inadvertently, increase the rates of formula or mixed feeding or people being advised to not breastfeed, because that is a concern. Regarding resistance, I have to say my understanding on this issue is that that resistance in this particular woman who's started ARVs for the first time on TLD, never been on another drug, on other regimens, a viral load with her that's not fully suppressed is extremely unlikely to be due to dolutegravir resistance, and more likely due to adherence difficulties. That's not the case, with other regimens, but on TLD first line, it's very, very uncommon for her to develop resistance, certainly in that period of time. So I don't think there's such a big, and the reason I'm raising that is because the only real recommendation to potentially avoid, and even then it's for discussion, breastfeeding, is in a person who's on a third line antiretroviral regimen and they're not suppressed. In that case, one would probably come out more clearly and recommend replacement feeding that should be funded.
Okay, great. Thank you so much. Should we move on to the next case study? James, do you want to go through your case?
Sure. Let me just try and share.
Yeah, it's coming up.
Okay.
Great. Well done.
So I have a scenario, and I'm just going to go through it, and I think it'll raise a few issues as we go along. So here's a 3-year-old girl who was diagnosed with HIV infection at birth. She started ART on day 6 of life with AZT 3TC nevirapine. She switched to abacavir 3TC lopinavir ritonavir at 4 weeks of age. However, she has struggled to take her ART, and her mother reports frequent spitting out of medication, especially the lopinavir ritonavir solution. Her mother tries to repeat the dose when this happens, but sometimes she spits it out again and it ends up in a big fight and she gives up. She has had 3 viral loads more than 1,000 copies per mil, and has missed or was late for 3 clinic visits and medication collections during the last 12 months. And she doesn't always have money for transport. Her current weight is 13 kilograms. So I'm going to put the first question to Helena, because Helena is busy doing an outreach visit to this particular clinic, which happens to be in Caledon, which is about an hour or 2 away from Cape Town. And what I'd like to know from Helena, who would have to obviously look at her history and charts of this child at the clinic, is what ARV formulations and doses are likely being used in this 3-year-old's current ART regimen. So this is speculating, but if you look, I want to just go through what might she be on as of current. So not new, but as of current. What do you think she might be getting?
Yeah, so I think it's a very frequent situation that we encounter. I'm sure everybody's familiar with a similar child in their recent past. So firstly, I think it sounds like she's on liquid formulation, and she's certainly on liquid formulation lopinavir because it says so. And she's 13 kilograms. So we know that on the weight-based chart, we start looking at tablets from about 15 kilogram, and then we can use the granules in the 40 milligram, 10 milligram granules in children less than 15 kilogram. But obviously she is not accessing those. It's also a possibility that she's still taking abacavir and 3TC as liquid formulation. And we are obviously always recommending now that we try to move all children to once a day abacavir lamivudine solid formulation with the 120/60 dispersible tablet. So dosing, I would need to look on the chart, but I think that's probably the formulations that she's getting. Oh, thank you. So this is awesome. I can't figure out if I have to put glasses on or take them off. but put them on. Okay, so, if I would guess, I would think maybe she's on 6 mils of abacavir twice a day and 6 mils of lamivudine twice a day, and then 2 milliliters of lopinavir ritonavir twice a day. Obviously not on the capsules of lopinavir ritonavir. So that's what I would guess is happening here.
Yes, great. And turns out that that's what she is on. So this is the 2021 chart. And the options really that she could have been on here are if she's getting twice a day dosing, as we often do with abacavir, lamivudine, and lopinavir ritonavir, just so that they're all 3 twice a day. Instead of some once a day, some twice a day, would possibly, as you said, be 6 mils twice a day, 6 mils twice a day, and 2 mils twice a day. This clinic did actually have 60 milligram tablets available, but the clinician wasn't very familiar with them, and the pharmacist said she would check and see if there were any in stock. But the other consideration, which they'd heard about but hadn't had yet in their clinic, were the lopinavir ritonavir capsules. So that's the 40/10 milligram capsules, only for use if not tolerating lopinavir ritonavir solution, and not used less than 6 months of age. So they were interested in maybe trying those capsules because it seemed that that was really the problem drug. And coming from the tertiary hospital, you'd had some experience with these capsules, and you decided to have a discussion about them with the clinician and the pharmacist.
Yeah, I think there's obviously a couple of issues here. So the one is clearly that from a formulation perspective, we can make things better. Or if not 100% better, at least try to make things better. Of course, there's also the history that she's really struggling to attend, which we also have to deal with. But I think here's a couple of things. So first thing is we can definitely try the capsules, and we can see here on the dosing chart that you need, I always have to check carefully how many you need, but it's quite a few, 4 capsules. So she would need 4 capsules twice a day, and that needs to be opened into a spoon. And usually we recommend that you put some yogurt or something in the bottom of the spoon, open the capsules on top, and then put something on top of that before you give it, because even though it actually, for some children, does alleviate the issue around chelator tolerability, when it touches the saliva, you eventually will taste that horrible lopinavir ritonavir taste again. So I think people may try different approaches, but without actually any new formulations available, I would try to move over to a solid formulation of abacavir, and I would even try once a day, because sometimes just taking a little bit of stress out of the morning and before the coffee goes into the veins is helpful. And I would definitely give the capsules a go, and try to be positive about it. Encourage the mom, but you also in the back of your mind know that this might not be the magic bullet for this patient, because there's still probably going to be some tolerability issues even with the capsule.
Yeah, thanks. So the pharmacist says she'd been to a webinar and she'd heard about this abacavir 3TC combination, and she saw that she could actually order it from the depot, and she said she would try and do that. She also just asked, in fact, the clinician also asked, well, can't we just use some of the Alluvia tablets and crush them, because that may solve the problem as well? And you see there's a dose in that weight band of 2 in the morning and 1 in the evening.
Yeah, James is being very deliberate because he knows I'm a big crusher of medicine, but not this one. So this is one where we really, whether it is still holds, we don't know. But the early data suggests that you should not crush this tablet because you make the pharmacokinetics very unpredictable and you often don't achieve a good PK and a good trough when you crush, especially in many small little bits. So you really don't want to crush this specific medication. So I would say rather try the granules and see how that goes. Don't crush the capsules. However, the tablets. However, she's 3. 3-year-olds like to do what their parents do, wear the shoes and all of that. Why don't we try to teach her maybe to swallow a capsule? She's quite young, but that is a possibility. And moving into the future, that will be a great idea if she's able to swallow capsules.
That's great. Yeah. So just the point about the lopinavir, ritonavir capsules are not for swallowing, but certainly the pediatric Eluvia, we do see children at surprisingly young ages who occasionally do manage to swallow these tablets whole. But quite right, based on clinical and PK data, Eluvia tablets should not be crushed, unlike many other tablets. So this clinician who looks after her, very keen and involved and has been repeating viral loads quite frequently. So she's had 3 viral loads in the last 12 months, all well over 1,000 copies. And she's been seeing this patient every month, insists the patient comes back for close follow-up, checking up. And unfortunately, she missed these 3 clinic visits and medication collections. So now she's wondering, with all of this, should she actually apply to the 3rd-line committee for genotyping and get approval for a resistance test in this child? And you kind of are one of the people who's on that committee and wonder whether, in fact, that's the right thing to do. But what were your responses to her in that regard?
So I think fundamentally, the adherence assessment is absolutely key. And the best way to assess the adherence, we know that she's struggling, so we accept that. But one of the best ways to assess the adherence is actually to check in the past 12 months, how many visits did the patient have? Did they pick up their medication on time? So if you go into the new guidelines, you'll see there's that specific assessment that we have to do to access the resistance test. And it is going to be each of our clinical judgment whether the patient meets that threshold. This patient has been failing for more than 2 years. So certainly from a duration on treatment perspective, over and over qualifies. But we don't want to do a resistance test if the patient's not taking any treatment, because then we're not going to pick up any resistance. So I would say in this case, even though there are those episodes where she's missing, if she's been taking a good amount of treatment in the last 3 to 4 months, and she attended regularly, and there's still not suppressed, I would actually ask for a resistance test. And in the meantime, still make those changes to make the treatment easier for the patient.
Yeah, thanks very much. And I think, she would sort of meet criteria, or at least most of the criteria for a genotype. She'd been on a lopinavir, ritonavir regimen for 2 years, more than 3 viral loads, over 1,000. The adherence is questionable here. And the way it's put in the new guidance down at the bottom, you probably can't see that, but more than 80% pharmacy refills or attendance of clinic scheduled visits in the last 6 to 12 months. So, I was being devil's advocate, but if she missed 3 visits, which means 9 out of 12, which is less than 80%, which means that she comes down this channel in the algorithm on PI for at least 2 years, 2 or more viral loads, more than 1,000, adherence under 80%. And here's the kind of planned hopeful intervention, the 4-in-1 that I mentioned in the talk this morning, which we hope is just around the corner for us, but is SAHPRA registered, but not yet in clinic. So the abacavir, lamivudine, lopinavir, ritonavir capsules that contain powder for suspension in water and taste pretty good, as a sort of an interim intervention to see whether you can actually achieve viral suppression on that, in which case you could then graduate through to the abacavir 3-TC dolutegravir regimen. However, the current state of affairs is we don't have that on shelf, and this child would may well gravitate down this route here in discussion with the expert who's been discussing with us to consider genotype testing, and may end up showing PI resistance. Either way, the child may well also be heading towards a Bacavir 3TC dolutegravir regimen. And the 2022 dose chart makes provision, as you can see over here, for this child of 13 kilograms to get 2 Bacavir 3TC combination tablets dispersible and 2 tablets of dolutegravir dispersible. That's 4 dispersible tablets once a day. And that is would probably resolve a lot of this child's problems, provided the mother's on board, hasn't given up, and is committed to treatment. So that's what we're moving towards, but it's a kind of a circuitous route to get there. And I'll leave it there. Thanks a lot.
Okay, thank you so much. So I think that was great on the case studies, and I think making that practical was quite good. I just want to finish off with some of the last questions that people, so the last 5 minutes, just spent some time on the questions. So we've been speaking about these new regimens coming out. When do we actually anticipate to start these new guidelines? So what is our timeline going forward? And maybe Helena can answer a little bit of that for us. So how are we going to get, what is going to be the process in the next couple of months to get where we want to be?
Yes, I think Mo also outlined some of this morning. So at the moment, we expect the guideline publication, the final guideline publication, to be imminent, but I think we have shared with you the most important and significant changes that we expect to see in the guideline document. We have approval for the dispersible dolutegravir, and we expect, I think Mo already said this morning, around April for us to start getting some kind of idea of access. So different provinces and different areas may have different processes. At this stage, I think, for instance, in the Western Cape, we need to take this through the provincial PTC. So those processes, if you are involved with any of these processes, it's a great idea to make sure that all of these things are on track, that we are ready to roll when we get the green light. What I would suggest is that we also, especially those of us with bigger clinics, that we also start to understand what is happening in the clinic, so that we are also ready to know who's going to need resistance tests, who's going to be able to switch easily, on which children must I actually first have an adherence intervention, or maybe already have a discussion with the hotline or the clinician society experts, so that you know that as soon as we have the drug available, that you are able to order and start switching patients. Also, I would say start looking at how much Calitra you've got on shelf, and maybe make sure that you have enough for it for every day for every child, but that doesn't need to be 6 months worth of stock now standing on your shelf. I don't know if Mo or if James has any other wisdom as well.
Yeah, maybe just to say, so I think it's going to be one of those things where we're very dependent on how quickly drug comes into the country. My suggestion is really around engaging with your pharmacy at your site and making sure that that they order drug as early as possible, so that you have it available. So I think that as Helena has mentioned, the idea is really around having the guideline available and the training and the discourse around it to start as early as possible, with the implementation happening from the 1st of April. Again, many of that, some other components that are not drug related, probably will change, and that's related to the change in the in the viral load cutoff, both in terms of the vertical HIV transmission stage, but also in terms of the chronic treatment phase. The other one that we haven't mentioned is really around that we've dropped the weight criteria for transition to TLD. So previously we had both an age and a weight criteria of 35 kilograms. So in the new guideline, we'll now be in line with the WHO guideline, and children, adolescents who are more than 10 kilograms and more than 30 kilograms can go on to once a day TLD, which is also increases access to a once-day regimen.
Okay, that's
Brilliant.
great. I've got two quick questions that I want to ask. So the one, I think, Mo, is going to have to be for you again. I don't think we touched on the Bactrim prophylaxis. So if you can maybe just recap what's going to happen to Bactrim prophylaxis in the kind of new guidelines.
Yeah, so I think the one main thing is that so at the current moment in time, the recommendation is that that we will start Bactrim prophylaxis at 6 weeks of age in all HIV-exposed infants, and that you will stop it once you have a negative PCR done at that 10-week visit, or after you get that result. The new guideline will be a bit more progressive in terms of decreasing the use of cotrimoxazole prophylaxis, in that you will not start cotrimoxazole prophylaxis in these infants. Only infants who test positive. So if an infant at 10 weeks has a PCR and you get that result back at, whether it's at 12 weeks or 13 weeks, and that comes back as positive, then that infant, together with the antiretroviral treatment, will start on cotrimoxazole prophylaxis for the first year of life. So just to reiterate, we're moving away from initiation of cotrimoxazole prophylaxis in all HIV-exposed infants to cotrimoxazole prophylaxis in all HIV-infected infants. The prophylaxis in adults and in older children remain the same and are CD4 count driven. So if the CD4 count is low, both in older children and adolescents and adults, you will then reinitiate cotrimoxazole prophylaxis or start cotrimoxazole prophylaxis if that's their first engagement in healthcare.
Okay,
Hope
great. And then,
yeah.
Okay, that makes sense. And then one more, will we need a viral load to change from a Bactrim 3TC Kaletra to dolutegravir?
Yeah, so I think the one thing is we do want to make sure that we facilitate the transition to a optimized once daily regimen. So the current guideline, and I think James has put it up on the screen, is that we don't require a current viral load. So it's we'll use any viral load in the last year or the last 6 months that's available, and based on that viral load, we make a determination and that algorithm in terms of whether they're on antiretroviral treatment if they're on a PI-based regimen for less than 2 years, irrespective of the viral load, they will transition to an abacavir 3TC dolutegravir-based regimen. And if they've been on that on a PI-based regimen for more than 2 years, and that viral load remains has been more than 1,000 copies per ml, then that algorithm in terms of looking at adherence, optimizing adherence, and considering whether to do a viral load, a resistance testing will then kick in. So again, I think just to reiterate, you don't need to have a viral load immediately at the time of transition. And certainly if they've been on a PI-based regimen for less than 2 years, your switch to an abacavir 3TC dolutegravir regimen is irrespective of that viral load. So we do hope that makes that transition as easy and simple as possible.
Okay, great. That's quite clear. Just one more last question, and then we do need to wrap it up. Is I saw a couple of questions about TB and HIV, and we used to wait 2 weeks with TB or with ARVs when we go on to TB treatment or make the diagnosis of co-infection at the same time. So we used to do 2 weeks of TB treatment before we start ARVs. Any comments on that? How are we going to move forward, and what would be the guidelines?
Yeah, so I think the WHO guideline has shifted and there was a systematic review of the literature around co-treatment, and really I think the main issue is around iris, development of iris. So the current guidelines is really around that there's, that 2 week waiting period is not a necessity. So in a stable patient, you can initiate both TB treatment and antiretroviral treatment at the same time. Certainly, I think in my clinic, what we do is in sick children where they admitted and there's they're on a lot of medication. We do wait a week, but they're in an inpatient setting where you can control that. But certainly from a outpatient setting, we don't want to send a patient out who's HIV positive, not on antiretroviral treatment. So in a stable patient, you can start it concurrently, and there's no contraindication to do that. The only exception is, really around CNS disease, because of the, in iris, in the context of CNS disease and exacerbation of the raised intracranial pressure, that would be the only contraindication to initiation of TB treatment and antiretroviral treatment.
Great, thank you so much. Over to you, Mignon.
Great. So that just leaves me to thank everybody involved tonight. It really was a great session, both this morning and this evening. Thank you very much to the speakers, to Mo, Helena, and James. Mo, you're brilliant at thinking on the spot. Helena, you may have had a hitch with Zoom this morning, but you answered all the questions by typing, so fantastic. And James, thanks for just keeping it really practical. The brainchild, Marti and Valencia, thank you for putting this together.